and volume management is what I call the elephant in the dialysis facility, because it is one of the most difficult problems for us. Our patients have very few joys in life, and they have a lot of dietary restrictions, a lot of fluid restrictions. They have to come to dialysis 3 times a week. And this is just one more thing that we're having to teach them to try and do, and that's difficult for them to do. So a lot of our patients, as one of the presenters said today, choose not to follow advice, and they think we can just take off the fluid. Well, when a patient has a catheter, it's fairly easy to take off quite a bit of fluid. Even if they drop their pressure, we can give them back some fluid and we don't have to worry about their access. However, when they have an arteriovenous access, and the graft, the HeRO graft in particular, is a very long arteriovenous access, and so that what we need to have is an adequately functioning heart that can pump blood at an appropriate flow and pressure through the arteries, into the graft, all the way along the HeRO graft and into the right atrium. It works extremely well if the patient's cardiac function is working well and their arterial inflow and systolic pressure is what it should be. But when we have all of this extra fluid on patients and we're trying to move a lot of fluid from the extravascular space to the intravascular space and pull it off very quickly, what we'll see if we pull it off too quickly is that the refilling from the tissues cannot keep up with the way we're pulling from the blood. And so the patient's blood pressure drops dramatically. We call it crashing in dialysis, and they literally do drop their blood pressure to a point where we can't measure it. Some of them even can lose consciousness because of it. And we have a medical emergency on our hands right then. We can give them the fluid back right quickly. But what happens, though, in that time is that there's no blood flowing through the graft. And when you have stasis of the blood, you're going to have clotting. Now, a catheter patient doesn't have to worry about that because we can flush the catheter and get it going again. We can't do that with a graft in a dialysis facility. If they go home and clot off their graft and come back 2 days later with a clotted graft, we now have another medical emergency. We've got to send them to the hospital, have them declotted so that we can do the dialysis that they need to live. So it becomes a really difficult cycle problem. And so that we have to educate both our staff and our patients in limiting fluid removal and teaching the patients how to limit fluid intake. Otherwise, we have to bring them back for an extra treatment to try and get that extra fluid off. So yes, that is extremely difficult in assessing how a patient will do with this very long access. There's another thing that has to be taken into consideration. A patient who has a catheter doesn't have quite as high a cardiac output as a patient who has this very long graft. Even a conventional AV graft, when it's first put in, you're suddenly rerouting a lot of blood at over 1,000 mils per minute through this graft. And the heart has to work harder and faster in order to keep up with that demand of this new graft. And in the heart, it's an amazing organ how it can compensate for this increased cardiac output. But it takes usually a few days, if not a few weeks, for it to do that with this new graft being placed. I don't think that this is a new problem. I think what is new is what we're understanding is that we need to deliver better quality care at a lower cost, because we know that we have not been doing that over the years, and the Center for Medicare and Medicaid Services are saying enough is enough, and we're going to start penalizing you with these QIPs if you do not fall into the guidelines and come up with the outcomes that we expect. And the rehospitalization of patients is one of those outcomes. And we know that fluid and volume management is a key player in both sending patients to the hospital in the first place and sending them back again if we don't adequately correct the problem of fluid and volume management. So I think that that's why we're seeing the emphasis now more than it being a new thing. And I think it'll benefit everybody, especially the patients, and that is what is most important.